We cannot host shared learning webinars without the input from people who are bringing our CWPAMS programme to life across the 8 African countries and the UK. Today, I'm delighted to be hosting our very first webinar, Using Data for Action. Through your respective projects, a lot of data will be produced, including point prevalence surveys as a mandatory aspect. Therefore, we really wanted to open with this important topic to remind ourselves of the value of data when it comes to antimicrobial resistance and the importance of collecting, analysing and interpreting this AMR data for action. Locally, data is important to improve patient health. At a national level, data can inform health policies and responses to health emergencies. And globally, data can be used to provide early warnings of emerging threats and help identify long-term trends. And this is why the funders of CWPAMS, the UK Department of Health and Social Care, the Fleming Fund, believes in evidence-based decision-making and is heavily invested in supporting systems which generate data. Data should be useful, usable, and used. And that's why we're here today with our partners from the Global Point Prevalence Survey and the Change Exchange. We'd like to bring our health partnerships together to understand that data collection is only the beginning. And it is so important that we consider how we use the data locally to develop interventions, but also share data and our successes widely to impact on the work of others and collaborate in the global effort to improve antimicrobial resistance. So I'd just like to take you through some housekeeping for today. Here's our agenda. So we're aiming to close by 2:30. Next slide, please. So we will be recording the session and you will get details of how to access that recording on demand after we close the session. If you haven't already done so and you didn't have time in the waiting room or pre-session, we'd ask that you take a few minutes to complete the pre-session survey via the link in the chat. We want to use this really to prove the value of these sessions, but also to get some evaluation from you about how we can improve these sessions and what you'd like to see in the future as well. So please do take that time. We really want these shared learning webinars to be very interactive, and we'd encourage as much engagement as possible. But please, for the sake of our speakers and the number of attendees we have, please keep your microphone muted during our presentations. If you'd like to participate in discussions after our speakers have been on, then please do raise your hand and we can invite you to turn your microphone and camera on. If you don't want to talk via microphone or you can't, please submit your questions via the Q&A tab or comment in the chat. And we will have a bit of time for questions following each presentation, and then we'll have a panel discussion as well. So that brings me to introduce our first webinar presenter, Annelies. And it's great to introduce Annelies from the Global Point Prevalence Survey. Annelies is one of the new members of the Global Point Prevalence team and has started her PhD on antimicrobial use in outpatient care worldwide. So Annelies is here today to give us an overview of the new outpatient module of the Point Prevalence Survey from the global team, which we are so excited about. So I'm going to pass over to you, Annelies. Thank you very much.
Thank you very much, and a good afternoon, everyone. Please hold on, I'm sharing my screen. Okay. Can you see my screen? Okay, great.
Yes.
So thank you all for coming and listening to this webinar. I wanted to introduce to you the very new outpatient module for the Global PPS. This module was launched in at the end of April this year, so it's brand new. But I first wanted to explain why would you participate in our outpatient module for the global PPS. Well, it's the global PPS is a well-established method and know-how, and we currently already have an inpatient module, and we really wanted to extend this based on some requests of participants of the global PPS. It's also a standardized method, so you can compare easily between countries and regions, and also between different surveys that you participated in yourself. It's an available web-based tool, and it should be, it is a straightforward addition of the new module, and it should be quite user-friendly. At least that's what we're aiming for. And we also have in our team, we provide you with support and feedback, and we try to answer all your questions and help you at the best we can. And furthermore, it's a sustainable method, so you can participate multiple times a year and also multiple years. So if you enjoy participating, or you're interested in for the future in participating again, you can. So this all should allow for easy implementation of the new outpatient module. And advantages of the outpatient module are that it's a simple method. The global PPS, or the PPS in general, is a simple method. You can quantify and evaluate your results very quickly. It's a minimum workload. It's 1 day of work. It provides you with detailed information on antimicrobial prescription in your hospital, and you can follow up prescribing patterns and behaviors over time if you participate multiple times a year or multiple years. First, I wanted to show you the road traveled. So what has happened in our past, and that led us to introducing the outpatient module. Well, in 2021, we obtained financing of the outpatient module by bioMérieux. Then in 2022, the protocol was developed for the outpatient module. And in the beginning of this year, an extension was developed for the global PPS website. So you can go to the same website, and it should be quite easy, hopefully, to find it. Then in March, the very first pilot data from Nigeria was entered. And then at the end of April, we released the outpatient module. And from May on, it is possible for hospitals worldwide to collect their data. And for the future, for us, for the global PPS team, we are developing extra slides and a feedback report. So it will be easier to get your data analyzed by us. I wanted to give a big thank you to all participants in the Global PPS Network. Without them, this wouldn't have been possible to create the outpatient module. So thank you very much for all your help. I want to especially thank Nigeria, Togo, and Burkina Faso, because they are piloting, they have piloted, especially Nigeria has piloted our outpatient module. They were the very first to collect data on the outpatient module, and also Nigeria was the very first to enter data in our outpatient module. So thank you very much. So if you're interested in participating, you can. For hospital departments, it's possible to participate in the outpatient setting. Emergency departments, for example, all outpatient departments, of course, and day surgery departments. But it's also possible for outpatient clinics, such as dental clinics and ambulatory surgery centers. And also for primary or community healthcare centers, such as general practitioners or healthcare practices. Also, of course, for other, if your center or your department is not listed, it's mainly for patients who do not stay overnight. The data we collect for everyone, all participants, those with and without antimicrobial prescriptions, we collect the information on their age group, which is adults, children, and neonates, on sex, on symptoms, presenting symptoms on the day of the survey, and also admission status. But admission status is only for those patients in emergency or observational units, because it's sometimes difficult to determine for those patients whether they are inpatients or outpatients, because they can be referred to another department. So that's why we added that variable. Furthermore, for each patient that was prescribed a new or ongoing antimicrobial on the day of the survey, other variables are collected, mainly the detailed patient data, which contains of the specific age of the patient, also biomarker information, rapid diagnostic test information, and point of care test information, and information on underlying morbidities. Also, information on their antimicrobial prescription is obtained, of course, and this includes the generic name, the dose, the intended duration of therapy, the clinical diagnosis, the indication, which is community or healthcare acquired, and also whether the prescription was prescribed according to local guidelines. And local guidelines are guidelines from the hospital or from your region or from your country. There is an important difference with the inpatient module that I wanted to highlight, and that is the collection of the denominators. In the inpatient module, the collection of denominators is at ward level. So you collect information for all your patients who have received an antimicrobial prescription, and then for your ward, you collect the number of admitted patients. So for example, if there are 10 admitted patients and 5 of them have an antimicrobial prescription, then you only collect detailed information for those 5 with an antimicrobial prescription. But for outpatients, this is different, because you collect general information for all people, whether they have received an antimicrobial prescription or not. So the denominator is at patient level. You can also, if you want more details on this, you can also see our protocol and our data collection templates at our website, which is here below. So if you're interested in participating, you can go to our website, and then you can scroll down until you see the data entry on the right. And when you click on read more, you go to our application where you can enter the data. There you can register or log in, and you can create or select the appropriate institution. If you already have a hospital with inpatient departments, it's possible to just extend that hospital with outpatient departments. So you just enter outpatient departments for that same hospital. And then you can register for the appropriate survey. So it's the year, and then we have 3 different periods from January to April, May till August, or September until December. So if you wanted to collect your data now, you would fall under the May until August period. Then if you have registered for that survey, you see this screen appear, and this means that you can register for the basic global PPS, which is the inpatient global PPS. Then we have an HAI module, the healthcare acquired infection module, which is an extension of the inpatient module, and you can also select the outpatient module. It is possible to select different combinations, so you can do both inpatients and outpatients. The only thing is that you cannot do is select an outpatient and the healthcare acquired infection, because the healthcare acquired infection is really an extension of the inpatient, so it isn't compatible with the outpatient module. So if you're only interested in doing the outpatients, this is you can click on that and confirm, and then you're registered for the outpatient survey. After doing this, you can, in our website, go to surveys, and then you can go to outpatient module, and then you see that you're registered. And then the first thing you can do is add a new unit registration. So you add first your department information, and then you should complete all the appropriate department information, which is, for example, the number of physicians, the number of nurses present on the day of the survey. And after doing this, you can enter the patients present on the day of the survey. So for patients without antimicrobial prescriptions, you only complete the general patient information. And for patients who do receive an antimicrobial prescription, you complete additionally the detailed patient and the antimicrobial information. After you've entered all the data for all your patients present on the day of the survey, you finalize your data. And then after finalizing, you can verify your data, so check for completeness and accuracy of the data. And afterwards, you can, of course, analyze your data. And this is possible by going to surveys and then to export to download an Excel file of your data. And this includes three tabs. The first of the institution data, and then the unit form, so your departments, and then the outpatient form, so your patient information. And we have added in the patient information also information on the ATC codes and also the aware classification. So that is not information that we ask, but based on the data that you enter, we assign the ATC codes and the aware classification. So you can analyze that as well. And then for the next years, we are developing feedback slides. So if you're familiar with the inpatient module, you perhaps remember that there are feedback slides after you've finalized your data, and you receive those by mail, and it's analyzed a lot of information already. So we are hoping to introduce that for the next year so that you can analyze your data, not yourself, but you can use our feedback slides quite easily. And furthermore, this is also new from this year. We have an interactive online longitudinal feedback. So this is available for inpatients already, where you can click on the data you want to see, and then graphs appear, and you can see all the information that you'd like. And we want to introduce this for the next year for outpatients as well. So if you're participating this year, you have to wait a little before we can analyze the data for you. So that was my introduction of the outpatient module. Please let me know if there are questions.
Thank you, Annelies. That was really, really interesting, and it's really good to hear about the outpatient module. And there's been so many challenges, I think, in our CWPAMS partnerships about how do we take this forward into outpatients, and how do we get the audit data from outpatients. So I think there's quite a few partnerships that will be delighted to have a tool to really enable them to do this. So thank you so much. Does anyone have any questions for Annelies?
Yes, I have a question.
Thank you.
Theopista.
Hello, Theopista. Thank you.
Okay, I just want to know if it is possible to employ the use of global PPS to the community pharmacies. That's all.
It should be, yes, you can, for pharmacies, it's possible as well to use the information, to use the tool,
Thank you.
So community pharmacies can use the same tool?
Yes.
Okay, great. And we have a question from Raphael.
Hi, Annelien, thank you for a nice presentation. My question is whether there will be an embargo on one particular person's data, I mean hospital data, before it can be seen by others.
Sorry, can you repeat your question? If there's...
Is there any time limit?
Time limit before it can be seen by others?
Embargo between which other hospitals or other people are sharing my data for them.
Maybe I can help. Let me see if I can. Hello.
Hello, thank you, Anne.
Hello. Yes, we are also from the Global PPS team. My colleague Ines Pauwels, Annelies, and myself, Anders Porten. So maybe I can help a bit. So for sure, when you enter data or when you collect data, those data are yours and nobody else is able to see them at any point of time. We care a lot about data security. We work so much on that. So that's for sure. If you want to collaborate, like for example, within the collaboration of CWPAMS, of Spark, or any other collaboration, and you want to share the data, and for example, get a publication, then we can share your data, but only if you agree on sharing that data. So actually all is possible there, but definitely we will never, ever proceed to share your data without your permission. And even you will decide, you yourself, which data you want to share and which one not. So we are very careful about that. And it's also in the importance of the sustainability of the projects, because sometimes it can be quite sensitive data, especially in the inpatient setting. You collect resistance data. So we are very, very careful for that. So that's one thing. I hope this answers your questions. I don't know who asked the question again. Yeah.
Thank you, Anne. Yes, it is clear.
Yeah. And to come back maybe on the pharmacy data from the lady with the nice name, I forgot already, Timmy Toppy. Yeah, so the pharmacy data, I think you mentioned data collected in community pharmacy. I think, yeah. So yes, because the Global PPS for now collects data from prescribers, physicians, based in, or like Annelies presented, based in outpatient settings in hospitals, or primary healthcare settings, or clinics, like clinics for surgery, day surgery. Voila, she's going to show it. You see, so the real pharmacy, community pharmacies, it's not really the aim to, you will not be able to use that tool, no. Although we have another project with Nigeria, Togo, and Burkina Faso, where they do that exercise, actually. And there we collect the data using the Kobo toolbox, another mean. So the exercise is done there, yeah. Because indeed, that's also very interesting to collect data there. Very, very interesting. Maybe that's for next collaboration with CWPAMS. Who knows? Yeah.
Thank you, Anne. I think that would be really useful because, again, community pharmacy is one of the newer aspects that we know there are many challenges in our African countries in terms of stewardship in community pharmacies. So it would be really useful to explore that tool. So it's great to hear that's in development. And thank you for jumping in to support Annelies with the questions. You're welcome to stay on screen because there might be some more that you can help with. So I've got a couple in the chat that's just come to me, and then I'll come to a couple of the hands. So just one to cover is, there was one about time frame of collection and data. Is there a time frame for this, Annelies? For a specific centre, what sort of time frame are you looking for?
For the collection of the data, we prefer that if you have a hospital and you want to collect multiple departments, that you do so in the same survey, of course. So the time frame is the periods January to April. I hope that's what you meant.
But if locally we're collecting the data, if in a particular area, how long are we collecting that data for?
In a particular area, so not in one hospital.
So if, for example, if I was to do it on an outpatient unit at my hospital, is it 4 hours, the time period?
Yeah, that's possible. Yeah, we say at least 4 hours, but it depends on how big the department is. And if you have a very big department, you might collect for a whole day. Yeah, or if you
At least 4 hours.
at least for hours, yeah,
Great.
not more than 1 day.
Thank you. And there's a question about the other patients. So patients who are coming into an outpatient department who were prescribed but didn't receive it. So
Okay.
I suppose
Um,
that wouldn't go together, would it?
So you mean that, for example, let's say an emergency ward or any wards in a hospital. So it is really aimed that you survey a specific number of hours, and following the protocol, we set, let's say, 4 hours minimum, but it can be that you have only consultation for 3 hours, then you do the full 3 hours. So, but every patient attending this prescriber should be, you record some basic information. Yeah. So, and you record the basic information for all those patients who get on consultation to that specific prescriber. If this patient receives an antimicrobial, an antibiotic, an antifungal, an antiviral, antituberculosica, then you collect a little bit more data, detailed patient data like you see on the screen. So that's how it goes. So there is no sampling, that's an important thing. There is, please, no sampling. So it is very important to have the full denominator. So we have the full picture of all the patients attending your practice or a specific prescriber. Yeah, and then you collect these basic data, and in case your patient gets an antimicrobial, you collect a little bit more information, which is written there, the 2 box below. Yeah, so I saw also a message passing that imagine that you collect also non-prescribed antimicrobials. I saw it somewhere, but I don't see all the chats. Let me see. Chat. There are so many. Oh, there are many questions. Maybe I give the lead to you, Fran, because I see a lot of questions.
Okay, so
yeah.
that's fine. If you see any questions in the chat and that you want to answer in the chat,
Yeah.
then please do feel free to respond. I'll go, because we are a little bit limited for time. So I'm going to go to the 3 people that we've got hands up for. So John, you're first on my screen. Do you have a question for the GPPS team?
Yes, I do. Hello,
Hello,
you get to
John.
me?
Yes, thank you.
Oh, yeah. Thank you very much to the team, and thanks, Diana, for the presentation. It's really informative. My concern is I'm from Sierra Leone, and there are a couple of times where inpatients come into the outpatient department, and they actually prescribe antibiotics, but they do not receive those antibiotics. What do we do for those type of patients? Are they included?
Yes,
Or
they are
not?
included. Yeah, they are included. Yeah.
And also, yes,
They are-
but
Yeah,
that brought
yeah.
me to the next stage question.
Yeah.
I didn't see in your presentation what's the inclusion and exclusion criteria for patients to be included into the point prevalence survey.
Yeah, that's a very good one. So you really include all patients attending your consultation. And so for this one, also those, for example, who are attending for cardiac issues. Of course, I hope they will not receive an antibiotic for, a cardiac, or maybe, when it is not needed. So this is your denominator, and that makes it also simpler that only for those who have been diagnosed with an infection, any infection, you collect detailed information. So this is your inclusion criteria. So you have, it's really, quite simple, if I can say. And if he has been prescribed by the physician, but your patient leaves your consultation and he has to collect the antibiotic to the pharmacy, you will not know if you will finally will take it, yes or not.
Exactly.
That is missing information. You're right. That is missing information.
Yeah.
You will not know. But at least
again,
it's prescribed. Yeah.
yes, but again, in most low and middle income countries, it's very difficult from the outpatient department for them to evaluate and say, okay, this person have an infection. It's mostly for example, common cold, somebody coming common cold, maybe it's not even, and it's not an antibiotic, it's not a bacterial infection, but they prescribe based on just the clinical presentation. In that case, what will you say? Is it diagnosed, or is it based on just clinical presentation, which is most of the time not accurate?
Yeah, that's a very good point. That's why we collect symptoms for every patient. You see it on top, general patient information. So we collect, for example, symptoms really referring to upper respiratory tract infections like fever, throat pain, cough, sneezing. So, and then we hope to find a difference with the next stage. If this patient has, for example, hardly symptoms, and no symptoms for like referring to the upper respiratory tract infection, but still he gets an antibiotic, then we can reflect, is that appropriate? Actually, we just had a discussion with our Nigerian team. He's not here. But he made a good remark also, and maybe we will change our protocol in the future already, because he found that we should add diagnosis like, for example, sinusitis, that we should collect that already for all patients seen on consultations, because then you will know for sure, then you will have more evidence that, okay, this prescriber, or in this kind of setting, they prescribe already an antibiotic, and in others, maybe not.
Okay.
So that's how we hope to assess the appropriateness of the antibiotic prescription. But for now, it's with symptoms, and then the specific antibiotic which is prescribed, and some quality indicators, and the intended duration prescribed according to local guidelines. These are really our quality indicators that we want to assess, and also linked to underlying morbidity. So if would be, we are, you know, this is quite novel, if I can still add, Fran, I'm sorry. So if you look at our protocol and our data collection templates, if you have thoughts about it, please get to us. We are very happy to learn from you.
Okay.
Thank you.
Yeah, I think that's important. Yeah.
Thank you, John. And I can definitely advocate for the Global PPS team being very responsive to these queries. I trialed this in our emergency departments in Manchester as well, just to really try the tool out, and I was really impressed with the tool, but also with the support from the Global PPS team, because Anne's right, this is a novel tool, and this is something that, you know, will be tweaked a little bit to get right for those areas. So I think it's great that, you know, this new tool is available to us. We've just got time for maybe one or two questions. We will come to a bit of a discussion at the end. So, and Anne and her team are available, hopefully, to answer some questions in the chat.
Yeah.
So I'm going to come to you, Herbert, please.
Thank you very much. My question is about account creation. Is it possible for a focal person that is implementing the grant to create multiple accounts for the sites or hospitals where this data will be collected? Thank you.
Yes, maybe our Lies can answer.
Oh yeah. It is possible. You have one main hospital administrator, and then you can add multiple users who can also access the same data. So it is possible to work with a team on the data.
And at the same time. Yeah. So it's
Just a follow-on question. So I understand for one site, like one hospital having multiple people.
Yeah.
Yes.
If you have like, let's say 20 hospitals that you want to survey as part of the activities being implemented under the grant for a specific partnership. So the accounts have to be created in the name of the hospital administrator at each of those sites.
Perfectly possible. Yeah, we have that worldwide. We have that in specific countries where data management is really centralized, so that there is one person overall. We call it the local administrator, and he's overseeing all the data. So that person has access to all the data, but this person has the right to provide access to specific parts of your data. For example, one hospital, you create an extra user for example, 1 or 2 hospitals, and this person, that extra user, will only have access to those 1 or 2 hospitals. It's written in the IT manual, how you have to go about it. Yeah. So as local administrator, or you can create as many hospitals as you like. You have access to all those hospitals and all those data from those hospitals. And by hospital, you can create extra users and even attribute a user responsible for data collection for that hospital. But the nice thing is that you oversee all the data and that you will be able to download feedback reports for all those hospitals and even merged feedback reports. For example, if you have hospitals in a specific region, you can download a merged feedback report for only a set of hospitals. All of this is possible, yeah. You can try it out. We can open a pilot survey maybe if you like, and you can even try it out. So just get in touch with us and we will guide you on that. Yeah.
Okay, thank you so much. To all of those people who still have their hands up, if you could maybe put your questions in the chat or we can come to them at the end, hopefully. Thank you so much, Annalise and Anne and Ines, for that really informative discussion around that outpatient module. And I would really encourage our health partnerships to go and have a look at that outpatient module and see whether there's something in it that they can use within their partnerships. So please, I really would encourage you to do that. So I am going to move on to our next speakers now, who are from the Change Exchange. So we'll just get our slides ready, but we've invited the Change Exchange here today. So we've got Professor Jo Hart and Professor Lucy Byrne-Davis, who have various hats in terms of health psychology and are very much, the experts in this, and are doing various different bits of work, but AMR is a real passion of theirs in terms of, really thinking about implementing behavior change and antimicrobial resistance and stewardship. And they've been working alongside us and our partners, THET, for quite a while now. So I'm delighted to introduce them, and I'm really excited to hear what you've got to say. So thank you, Jo and Lucy.
Thank you, Fran. Thanks for inviting us to talk today. I'm Lucy Byrne-Davis, and my colleague Jo Hart is going to present some of our slides a bit later. Just to introduce you to, we've met many of you, but to introduce you to who we are. We both are health psychologists, and I'm a professor of health psychology and Jo of health professions education. And we've done a lot of work with THET over the years on lots of different types of behaviour change related to health partnership work. And in recent years have worked quite a lot with CPA on antimicrobial stewardship related behaviours specifically. So we're really delighted to be here. And we're going to talk to you a little bit about what we did within CW PAMS, and then some kind of things that we found around the data that might be useful for partnerships moving forwards as well. Next slide, please. So we were asked to work with CW PAMS 1, and the first thing that we were asked to do was to do some initial training in behaviour change. So for those of you who were at the UK Inception event all those years ago in Birmingham in the UK, we did some initial training, a sort of workshop where we introduced the types of models and theories that we work with. So we tend to work with, there are, the last count was something like 86 different theories of behaviour, which is really not very useful for anybody. And so we work with one sort of umbrella framework that's aimed to bring many of those theories together, which I hope you're all familiar with now, the COM-B framework. And something called the behaviour change wheel, which helps us to think through the multiple influences on anybody's behaviour, on stewardship behaviours, and then potential ways that we might intervene to support people to change what they're doing around antibiotics. So we went through THET had funding for 4 partnerships to have change exchange volunteers working with them. So they randomly selected 4 partnerships out of the 12 to have that change exchange volunteer working with them. And one of the CW PAMS partnerships actually had a health psychologist, a colleague of ours, who was already funded as a co-investigator. So our volunteers did a variety of things. They joined visits for scoping. They worked on intervention development on the basis of what was found around behaviours in scoping, and supported teams to do follow-up and also to write up some of the findings as well. We also worked behind the scenes to support CPA and THET with the development of their overall evaluation framework, to add in some behavioural elements to that. And then we at the end of CW PAMS 1, we did a small study in which we analysed some of the delivery materials that the partnerships had prepared, and that's what Jo is going to talk us through next. Next slide, please.
Hello, everyone. Delighted to be here and exciting to hear about all the amazing work, and looking forward to CW PAMS 2 as well. So I'm going to talk about some work we did that was really quite specific in understanding from a behaviour change, from those theories that Lucy talked about, what could we see in the incredible work that the partnerships did that would help us understand what behaviour change was in there and might help partnerships in the future when they're developing their own behaviour change material. So we carried out some work as part of CW PAMS that I'm going to talk about in some more detail to give you some illustrations of the kind of things that we do when we're working with partnerships, but how we can look at the materials that people are creating for their interventions and their evaluation and analyse them. Next slide, please. So what we did was that we coded their intervention materials. So we asked partnerships to we asked partnerships to send us their materials so we could look at the interventions and the evaluation they'd created. And I've listed on this slide some of the aims of that work, which I'll just talk through briefly now. We wanted to understand what behaviours, so what were they doing, and what behaviour change techniques, how were they aiming to change behaviour, were being used in these partnerships with the aim of changing healthcare staff behaviours. To do that, we used empirical behaviour change guidance in a number of different ways, which enables that systematic characterisation of interventions and enables knowledge exchange. So what it means that if we have that systemic coding of what people are doing, then that will help partnerships to understand what is effective in what they've done already. And it might help partnerships in the future when they are designing new interventions. It means, the third point there, that we can generate quite detailed descriptions of what's going on and the mechanisms of action. So how is that change happening? And we can look at how much health partnerships are using interventions that come from theory in trying to elicit AMS, antimicrobial stewardship, behaviour change. So that's how we aim to work. Next slide, please. So specifically what we were doing is describing the features of the partnerships, using something called the TIDIA framework. There's a lot of acronyms on this slide, but I'll explain them on a future slide. But these are all frameworks that we use in behavioural science. So the TIDIA framework for coding interventions and saying what exactly they are. To identify what behaviours the partnerships targeted. So what were they trying to do? What were they aiming to do? Using another framework called the ACT framework. Again, I'll explain a bit more, but the target of the behaviour. What is the focus of that behaviour? To go into detail about how partnerships chose to intervene. So how were they trying to do those behaviour change in changing staff practice behaviour using something called the BCTV1. And some of this we described in our initial inception workshop with some of you in a few years ago now. And we also wanted to look at the partnerships that had behavioural science volunteers compared to those who didn't, to see if there was any difference in the approach they took because of that team member in behavioural science. Next slide, please. So the materials that we received data from 6 of the health partnerships that were involved in CWPAMS 1. So thank you very much if you sent us materials. Those partnership materials were all anonymised by THET. So everything was blanked out that would identify a partnership. So we in the Change Exchange didn't see any of that detail of who the partnerships were. What it included in those materials were things like the PowerPoint presentations that people used, leaflets, posters, prescription guidelines and resources, activity facilitator sheets, and sometimes the evaluation that they were doing. Next slide. What we then did with that is look at all of these in detail. So these are some examples of the kind of materials that we got. You can see the blanking out there for detail, and you can see that at least one of the partnerships used some of the WHO materials, which they sent us as part of that. So that's an example of the kind of materials that we received. Next slide. And here are the data extraction tools with these a lot of acronyms in here. So the first one here on the left is called TIDIA, which is a template for describing interventions and replications. So thinking about when you are designing an intervention, which might be something like education and training of healthcare workers, how do you describe it in terms of why you did it, what you did, who provided it, how and where. So it's a way of describing an intervention so we can really understand it in detail. We also at the bottom of this slide use something called ACT, which is the action, actor, context, target and time, is how we specify behaviour. So if there's a behaviour that you are doing, like prescribing something in a particular situation or stopping prescribing, then you are giving a very detailed description of what that behaviour is so that it's very clear what it is you're aiming to do. So we coded how detailed those behaviours were. And then on the top right, something called the BCT taxonomy, which is behaviour change technique taxonomy. And for that, we were really looking at coding things like capability, opportunity, motivation, and the behaviour change techniques. So thinking what were the very specific things that you were all doing in your interventions that would change practice. So that's how the tools that we used. Next slide, please. And this is an example of the kind of table that we were filling in for each of the materials we were looking at. Next slide, please. All the materials were double coded, so we had 2 researchers looking at each one. They were blinded, as I said, they didn't know who the materials had come from or which had a change exchange volunteer attached to the project. There was lots of data where we couldn't code it in a particular way, so we just put in no data, and then we used content analysis to collate those target behaviours and the BCTs. At the end of that process, we were then unblinded, so we were then able to see as a group who had behavioural science and input or not, but that's after we'd reached all our conclusions. Next slide, please. So our findings, I wanted to give you an idea of some of the things that we found from these 6 partnerships involved in CWPAMS. So sometimes there was lots of healthcare workers targeted, sometimes it wasn't very specific. So sometimes the description would say something like dispensary staff or healthcare professionals, and not necessarily specify their professional discipline. And 50% of those partnerships reported the number of workers targeted in the intervention. Next slide, please. This slide gives examples from 2 of those 6 partnerships describing who the target intervention was with, who was the target of that intervention. So on the left-hand side, partnership 2, you could see that they listed a whole range of staff that were involved in the intervention that they did with them. You can see quite a broad spread. And on the right-hand side for P11, you can see that there's slightly less groups of staff, and they have specified for most of those groups how many people attended that education and training, for example. Next slide, please. When we looked across those 6 partnerships, we could see the number of partnerships targeting healthcare workers in different disciplines. So pharmacy, not surprisingly, pharmacy colleagues were targeted in each of those partnerships, and then a range of staff, but nurses and doctors in 5 out of 6 of those ones that we looked at, and then other staff in a number of them. Next slide, please. These were the behaviours that were targeted. So we identified from those materials that 19 behaviours came through, and those were in some grouped areas, for example, like hand hygiene, improving hand washing technique or the frequency of hand washing, prescribing antibiotics, so for example, specifically on antibiotic prescribing, or improvement in antibiotic use, and then some other things like wearing correct PPE, infection prevention and control, but not specified. So those are examples of some of the 19 behaviours that we targeted, that we found were targeted by the partnerships. Next slide, please. Then behaviour change techniques. So these really granular, exactly how are people aiming to change behaviour? We identified out of 93 possible behaviour change techniques that we have in our behaviour change technique taxonomy, that 21 of those 93 were used, which is about what we usually find when we are coding education and training. The most commonly used, so remember that for each of those partnerships, they have multiple materials and multiple parts of the education and training or other interventions. Most commonly was instruction on how to perform the behaviour that we coded 83 times, and then a number of others that were very commonly used, like adding objects to the environment. So that might be something like a different prescription chart or a poster. Information about the health consequences, so explaining what might happen as a result of antimicrobial stewardship or poor antimicrobial stewardship, demonstrating a behaviour, how do they do something, or practicing the behaviour or rehearsing the behaviour. So that's what we most commonly saw in what was used in those 6 partnerships. Next slide, please. When we looked then after all of that coding, and when we finished that coding, 2 out of 6 of the partnerships had a behavioural science volunteer embedded within that. When we looked at any differences that we could see, any themes between those partnerships, we could see that Those partnerships with a behavioural science volunteer from the Change Exchange demonstrated some more clearly specified reporting. So, for example, the duration of the intervention, how long education and training was, and that's typically how we describe things in behavioural science. But one of the partnerships that didn't have a behavioural scientist actually described the reported behaviours most clearly. Those that had a behavioural science volunteer included a greater variation of behaviour change techniques, so more of those techniques used to try and change behaviour. Next slide, please. So the implications of this, well, we could start to think a little bit more in our AMS work, how we can ensure that knowledge exchange and replication of these effective interventions. So like today, sharing this kind of information and thinking about how that might help for future partnerships. Can we develop a kind of reporting frameworks so that people can describe their interventions in a clear way and help others to do the same as what they've done, so they're able to replicate that very specifically. And for behavioural science, how can we carry on hopefully being useful to you all in terms of the benefits of behavioural science and how we can help you all to do even more of your amazing work. And we think some of that is through clear reporting and evaluation and helping you to understand the evidence of impact. Next slide, please. We've recently published a paper on this work. If you're interested in reading more about it, is openly accessible, and we're really happy to answer questions or have discussion now about this work or any of our more general work. And as I said, we're very much looking forward to working with some of you in CW PAMS too, and lots of other excellent projects. Thank you for your time.
Thank you, Jo and Lucy. Every time I hear you both talk, it really just makes me excited for what we can do and, you know, the opportunities really. So, and I thought it was really interesting to see that, you know, one of the partnerships that didn't have the behavioural science was still doing it. And I think that's sometimes where we fall down, that we don't believe that because we haven't got someone specifically attached to a project that we're not doing it. So is there anything that you can sort of give us tips, or is there any ways that partnerships can think more about that if they don't have, you know, some of our partnerships are on limited and restricted budgets, and, you know, is there anything that you can point our partnerships towards to really think about how they are doing this without someone directly attached to their partnership?
Lucy, do you want to start?
Yeah, that's such a good point, Fran. And what we find we found it a lot with pharmacists actually, and a lot with people working in antimicrobial stewardship, is that it's people. A lot of people are thinking very behaviourally from the outset. So sometimes with partnerships that are focused on different clinical problems, people haven't made that leap yet. That actually a lot of that is around behaviour, whereas I think antimicrobial pharmacy has made that link definitely already. So that's the first thing to say, that I think people are thinking behaviourally, and that is the first step. What we always say, it's like deceptively simple, but it is quite simple, and it's about understanding a person in their own context, what makes them do the thing that they are currently doing. So prescribe antibiotics in a particular way, for example, or take antibiotics in a particular way if they're a patient, and really trying to be curious about the multiple drivers of people's individual behaviour without judgment. So it's very much trying to understand a person in their context, and then thinking about what the evidence is, or what you've tried before, or theoretically what could support somebody to change given those drivers of their behaviour. And so it's not a magic formula, and there isn't amazing amounts of evidence for specific interventions, particularly not in the countries that are represented in CW PAMS, sort of low and middle income countries. The psychological evidence on behaviour change is low, because that work hasn't really been done And a lot of the theories that we're working with, all of the theories that we're working with really are developed in the global north. And so their kind of direct relevance, the direct evidence that we've got is actually smaller than it should be if that work had been done in a more equitable way. But what we advocate for very much so is that approach of begin by thinking behaviourally and then following people through within their context in a curious way. And that's what we're always advocating around taking that approach.
And I think it's really, and I know CPA and THET both say that less is more sometimes, that there is an awful lot of work in all of our environments that can be done, and some of this is a 20-year project that you know there's really interesting things to do, but sometimes by being very focused and specific on one change, on one behavior, and defining that very, very clearly, and then making a plan very closely related to that target behavior that you want to change, can give you really good evidence of being able to change something and knowing that you've been successful in changing it. And then you can move on, hopefully with the next set of funding, to the next other things that you want to change. So don't feel that sometimes going through that process of very much focusing on behaviours can help you think what's manageable and how will we know if we've been successful. And I think all of the support structures that are in CPA and THET really help you to do that.
There's a question there in the chat from Ayodele asking if there's tips on contextual factors that promote changes in behaviour. So it's a really good point, and we tend to think of context in two ways, really. There's a sort of physical context and a social context. And so the physical context is all of those things that you could imagine that remove the friction for people to do the thing that you want them to do. And so if your environment is set up in such a way that the desired behaviour is the easiest behaviour in that moment, then that is a context that is likely to nudge us into doing things in that way. So you might put friction in place in order to be able to do that. So you know, people do that sometimes in antibiotic prescription or antibiotic review by requiring a review. So you can only prescribe for 48 hours in the first instance. These things don't always work, by the way. I've got as I'm sure you all know much better than I do. But that's an example of kind of providing a point of friction where a behaviour can't be carried out. So a prescribing for 5 days can't be carried out because you can only do 48 hours. So there's that's that sort of context. There's also, again, in the physical environment, there's things that prompt you or cue you to do things in a certain way. And then there are things that make it easy for you. But the other part that is the social context is really important in antimicrobial stewardship in all behaviours, really. And it's whether or not the thing that you're requesting that person does is the way that we do things normally. Because if it isn't, then that provides a really strong reason for that person not to do it. And so if people have bad experiences, for example, non-prescribers, dispensers have bad experiences of potentially discussing prescriptions and non-alignment with guidelines, for example, with prescribers, and that's gone very badly, then that context is going to really work against that dispenser doing that again. And so sometimes you look at the behaviour of an individual that needs to change, but actually you then have to spread out from that person and think about what are the social pressures on that person to do or not do that specific behaviour. So yeah, there's lots of acting contextually, and often with stewardship interventions we revert very much to training, which is generally not about context unless it's training to manage your context, which you can add into training. But sometimes if it's training in how to do a particular thing, it might miss out on those important contextual factors. So it's good. It's really good that you're asking about those tips.
And I think sometimes something we really do come across in healthcare is that hierarchy, isn't it? And again, you know, talking about that social context, is so important, because, you know, you have the hierarchy of doctors, nurses, pharmacists, and those barriers that that creates. And also antimicrobial stewardship often goes with judgment, and traditionally has been very much a, you are doing the wrong thing. And I think what the angle you come from is very much, you know, bringing that together and having those conversations and doing it together, rather than it being the pharmacist are telling you you're doing the wrong thing. You know, behaviorally trying to bring that and take it away from judgment and blame, and bring it, how can we do something about this and improve it together? So yeah, you guys, every time you talk, it makes me think, oh, there's so much, like Joe said, there's so much we can do. Thinking about that small intervention you can make is so important, because otherwise it's overwhelming. Does anyone have any questions for Joe and Lucy? Oh, we've got one in the chat. So thank you for your great talk. How can behavior be modulated when dealing with contextual issues that are outside of the control of the actors, in this case the prescriber?
So are you talking there, oh hi Tunde, are you talking there about like availability, those kinds of issues?
Yeah, pretty much availability and system challenges that makes actors behave in ways they know that they actually ought not to, but they just can't control it. Thank you, and thanks for the talk, Lucy.
Thank you. Yeah, so I think if you know that there are contextual issues that are outside the control of the actors, then that's not the right place to be intervening, essentially. And so sometimes taking a behavioural approach means that we focus our intervention at a different level. So if you know that it doesn't matter what the prescribers know or what they want to do, so what their motivations are and what their capabilities are, that they are simply not going to be able to act in alignment with guidelines or whatever, then the intervention has to come away from those actors, because it's you know, as psychologists, I think Joe and I are very concerned about health workers working in very high stress situations, who are then shown a way that then told that they're not practicing in alignment with guidelines, and the potential psychological impact that has on individuals who want to do their best, you know, which most people do. And so continuing to intervene with an actor who is unable contextually to change their behaviour is probably ineffective and potentially damaging or unethical as well. So I think then the intervention has to be at the different level.
It might be then that there is an intervention that's focused differently. So, for example, to change the working conditions of those people, or their reporting requirements, or some resources that they might need. So you might be targeting the managers or somebody senior in a hospital, or I know some of you in these projects and in other previous projects have supported development of a monitoring committee in a hospital that is then able to have those conversations. So it might be that there is a different kind of intervention that then further down the line would help those prescribers, for example.
Yeah, but it's such a good question, because it is it is a situation that a lot of prescribers, a lot of people find themselves in, that they just cannot act in alignment with what they want to do. And yeah, I think our role then is to actually to reflect that back to project teams and to say, actually, this person can't do this. So we actually need to intervene at a different level. We need to regroup and decide what is going to be a successful way to intervene at this point.
And I think that's where it's so important that our AMS teams in our health partnerships are so multidisciplinary and also have that strategic leadership, because that's important. If you can't make things happen on the ground because of some of these issues, then actually you need to be changing your intervention, but you need to engage the right people, don't you? And so, you know, through CPAMS 2, we're really trying to think about how we also support those people on those AMS committees as well, in terms of, you know, what data is there, what decisions are there, how can we support those committees to know what to do with the data that they have. Because some of the conversations we've had in the inception events has really highlighted that we've, you know, partnerships have established these committees, but actually now we need to support and strengthen those committees as well. So definitely different factors of this, and really this displays the importance of having non-medical people involved in these projects, such as health psychologists. So does anyone have any more questions for Lucy and Joe? Can't see any hands. I'm going to invite Annalise as well, if you're still here, to come back as well, and we can have a bit of a panel discussion. I know we're slightly separate, aren't we, in terms of Annalise is at the start of that data collection and what we do with the data in terms of analysis, and then Lucy and Joe are at the other end in terms of how do we make these interventions stick. Do any of you have anything that you'd like to add, or has anyone got any questions that they'd like to put to the panel? We're all stunned into silence. No? Anyone?
Yeah, hello.
Hello. Hi, John.
Yes.
Thank you, John.
Yeah, thank you very much for the presentation. When it comes to issues that involve behavioral change, normally they are contentious issues, especially from my setting here in Sierra Leone, wherein, for example, you have a doctor and the pharmacist is coming around to say, doc, this is the behavior that is happening and it's impacting on antimicrobial resistance. How do we change this type of behavior? It's very difficult because most of the time the doctors are way senior and the pharmacists are just entry level, you know, that are practicing at the hospital setting. Now, in that context, how do you make that approach after you've analyzed data, found that there's a particular behavior that needs to be changed? How do you make a move to approach? Because the thing is, some of us, our training normally does not dive deep into the psychological issues that need to be handled, to be honest. So it's kind of a bit a new area, I would say, and implementing or using those tools can be a little bit intimidating, you know. But for stats, where do we start in approaching stakeholders in terms of changing behavior towards antimicrobial use and antimicrobial resistance? That's my comment or question.
Yeah, it's a big one, John. I mean, I think I would always start with questions, with curiosity, really. So I would never assume why people were doing things in a particular way, what was sustaining it, what their perceptions were of changing it, and what I would do is I would try to discover from people what's currently happening and why. And the other big thing that we talk about a lot in our practice as health psychologists is around bringing people with you, so participation of people. So people generally don't like having things done to them or about them or on them, and so the kinds of behavioural interventions that tend to be successful are ones where people feel in control of the change themselves. So so that the first step is people understanding that there is a potential problem of AMR in this particular case, which many people would know, I suppose, and it could be that the threat of it needs to be made more salient for them. So we talk about salience of consequences. So people people will know, often people know, but they think it's a very distant problem, and they don't realise that that the problem is quite close, and the potential devastation of it. So that's a kind of just a general sensitization or a general shift. And then it's really saying to people, so what do we do about that? You know, you're all prescribers. What's happening? Why are you prescribing in that way? It's asking questions and being curious. And then on the basis of that, then thinking about what has to be done next. But certainly change is more likely to happen if people feel in control of that change. And so bringing people along with you on the journey that you've gone on to mean that you want to act on stewardship, then that's likely to be the best first step.
Okay, yeah, thank you. That's very informative. I think the other point is because the presentation involved both data generation and how you use data to influence change, right? So now for us, we have a culture of generating data, then disseminating it for the short period during the time when the project is on. And after a couple of time, we fall back to the same things of behavior we are doing in the past, right? So how do you make sure that this behavioral change that you're trying to cultivate is sustainable? It's not just for the short term. It's something that sticks within the practice setting for the longer time. You know, how do you achieve that?
I can start on that. So it's such a good point, John, because you probably know, if you've ever tried to eat differently or go do more exercise, that starting is easy, and 6 months later it's hard to carry on with that behavior change, and often people don't. So it's the maintenance, the kind of how do you carry on with it is really, really important. And thinking about that sustainability right from the very start is really good in terms of a project plan. So what can you do that means that people have some refresher skills, or they have somebody that they can have a conversation with? And often what we do when we're thinking about planning is thinking about helping people put plans in place while they are learning about the behavior change. That means that if something goes wrong, we call them if-then plans. They know what to do in that situation, or how to plan for making something more routine or making it habitual. So we often start with the planning at the same time as a training or another intervention, because it is, for all of us, the maintenance of that is really important. Lucy, anything to add?
Just to say that that things, when you start to change a behaviour, it involves a lot of thinking. It takes up quite a lot of your thinking space. And that's often why people fall out of doing it, because the other things come along and they then push that bit of thinking space out. So the trick really is making something habitual before something else comes along that's going to have to be done. And the way that we make things habitual is practicing it over and over again. But it's also what I said earlier on about making the right thing to do the easiest thing to do. And so quite often our habits are supported by nudges, by prompts in our environment, or by monitoring, knowing that we'll be monitoring. And obviously we're talking about using data here. So sometimes data monitoring is effective if it's fed back to people regularly and in the right way. But really, because the next thing will come along, won't it? So we kind of target our health professionals and we say, this is the really big thing right now. And then we know that in so many months' time, there will be another big target for them to have to work towards. And so the kind of trick is to plan to try and get it to be fairly habitual, something that they're not having to consciously kind of control and take care of. before that next big thing comes along. And so definitely things that cue people in the environment, prompts and cues, and monitoring so that people know that somebody is monitoring what they're doing, and sort of positive reinforcement, so positive feedback about doing the right thing, but that kind of making it frictionless. You know, I often think of us as little balls in pinball machines, and that most of the time we're just being buffeted around by things that are external to us, and it's not that often that we get a chance to really think for ourselves. And so making sure that some of those things that are buffeting people around are pushing them, nudging them in the right direction, I think it is really good for sustainability.
Thank you very much. That's really helpful.
Thank you. I think, you know, that's so important in today's healthcare environment, isn't it? There's so many competing priorities. And if you can make, you know, like I loved what you said about making the right thing, the easiest thing to do. And if you can make that, and if you can make it a habitual change, then actually, you know, that's such a big win, I think, in terms of antimicrobial stewardship, so that someone's doing it even when the priorities change and, you know, something else takes their attention. That's now become a habit, you know, is gold. We just need to be able to do that for all the little things that we need to do. A magic wand would be lovely too. Does anyone have any more questions for our panelists? No? Well, I am going to ask our tech support to put my slides back then, please. And I will draw us to a close. So really, you know, just wanted to say thank you so much, first of all, to our speakers, Joe and Lucy and Annalise from the Change Exchange and the Global Point Prevalence team, and also Anne and Ines who've jumped in when we've needed them. You know, it's really been a delight to have you for our very first webinar and really bringing some thoughts and some great ideas into how we can use data for action. I'd also like to thank our CPA team and our THET team for supporting today, but also for the, you know, extended support of the CWPAMS2 programme and really everything that's going on behind the scenes. Thank you to our attendees and also our health partnerships who are making CWPAMS2 happen and will be obviously getting this data and putting this data to action. Thank you to our funders from the UK Department of Health and Social Care, the Fleming Fund. And also finally, thank you to Page Medical, who are our tech support for this webinar series and are really bringing everything together and really allowing us to get on with, you know, bringing you the information that's really important rather than worrying about the IT issues behind the scenes that are extra stress for everybody. So thank you so much for attending. You will get a certificate of attendance for this session. We also would really like you to bring to answer our sort of post-survey questionnaire that will, our post-webinar questionnaire that will come to you as well. And we've got some great news about the next webinar. So the next webinar will be held in October. And this is an introduction to clinical microbiology. So really about bringing some of the basic foundation core principles of clinical microbiology to you so that you can share them with your health partnerships. So we're hoping for this. I think we're aiming for the 11th of October, but we will confirm the date with you. So thank you so much for your time. It's been really great to have you here today, and have a lovely afternoon, everybody.
Afternoon. Bye.
Bye-bye.